Okay, let's talk about hypertensive disorder of pregnancy. Introduction. The hypertensive disorder are leading causes of maternal and perinatal mortality and morbidity worldwide. More than 99% of hypertensive disorder or pregnancy related to maternal death. Mostly it was in under-resourced setting worldwide. While perinatal death and maternal morbidity remain major challenge for healthcare provider, the estimated overall incidence prevalence is 11%. Globally, one woman dies every 7 minutes due to hypertensive disorder. As per ACOG 2013-20 described four types of hypertensive disorder: preeclampsia, eclampsia syndrome, chronic hypertension, preeclampsia superimpulse, and chronic hypertension, gestational hypertension. And diagnosis: gestational hypertension is defined as the BP that reaches more than 140 by 90 mmHg first time after 20 weeks of pregnancy in previously a normotensive woman but lack proteinuria or lack any feature of undergone MS. It will be a retrospective diagnosis, and the postpartum BP has to be written by the normal by 12 weeks. Preeclampsia, these are the definition. Preeclampsia, uh, hypertension plus proteinuria, like more than 300 mg per 24-hour urine protein creatine ratio is more than 0.3. Dipstick is 1 plus with or undergone MS like platelet count less than 1 lakh, creatine level 1.1 mg per dl, doubling baseline, no prior analysis, STLC level twice normal. Then cerebral symptom: headache, visual disturbances, convulsion, pulmonary edema. But the difference, as per ACOG, they are taken the dipstick reading is 2 plus, and the rest all the things are same. And gestational hypertension, the dipsticks, they also the same proteinuria criteria. And nice ISHSP 2 plus proteinuria, at least 2 per is also 2 plus proteinuria. Then platelet count is ISSSP is platelet count less than 1.5 lakh, and but in Williams it is less than. ISSP and NICE is 1.5 lakh, but here is 1 lakh. But epoxy there will be a typical variant like all this endocrine damage functions. And ISSP they added the extra things. ISSP and NINE's guideline they added the uteroplacental dysfunction like fetal growth restriction, abdominal umbilical artery Doppler, placental abruption, angiogenic imbalance or stillbirth, like this only. Indicator severity, there will be abnormal, non-severe and severe, less than 110, more than 110, less than 160, diastolic BP, more than 160, proteinuria, antiphospholipid, headache, visual disturbance, upper abdominal oliguria, if present, is a severe convulsion, serum creatine thrombocytopenia, serum transaminase level, fetal growth restriction, pulmonary edema, gestational age, early gestational age is more dangerous. Then chronic hypertension, blood pressure more than or equal to 140 by 90 mmHg before pregnancy or before 20 weeks gestation or both. Hypertension should be documented at least 2 occasions, at least 4 hours apart. Then preeclampsia, superimpulse, and chronic hypertension. In chronic hypertension, if new onset or worsening baseline hypertension is accompanied by new onset proteinuria or other finding, there will be evidence of preeclampsia. Eclampsia is convulsion occurring patient with preeclampsia are known as eclampsia. HELP syndrome in the form of severe form of preeclampsia that is characterized by hemolysis, elevated liver enzyme, hemolysis, blood, hemoglobin, bilirubin is 1.2 milligram per isolated, thrombocytopenia is 1 lakh, and STLT more than 70, and DS more than 600 in internal. The risk factor: maternal risk factor, maternal specific, pregnancy assisted, paternal specific, age younger age less than 20, more than 35, black rash, nulliparity from history of preeclampsia, preeclampsia in previous pregnancy. The specific medication: GDM, type 1 diabetes, obesity, chronic hypertension, renal disease, thrombophilia, metabolic syndrome, hyperhomocystinemia, CKD, SLE, stress. The pregnancy associated factor like molar pregnancy, multifetal gestation, then hydrops fetalis, oocyte donor, oocyte donation or donor insemination, prior abortion, prior stillbirth. Then paternal risk factors like first time father, previously father of a pregnancy. Another one, pathophysiology: the placental implantation with abnormal trophoblastic uterine invasion. One is the abnormal trophoblastic invasion occurring in 2 stages. Initially at 12 weeks up to the decidua, and after that it will be enter into the myometrium. That is 16 weeks it will complete complete trophoblastic invasion occur at 16 weeks of gestational age. Another thing is dysfunctional immunological tolerance between maternal fetal and fetal tissue, maternal maladaptation to cardiovascular inflammatory changes of normal pregnancy, genetic factor that include predisposing genes, epigenetic influence. This is a pathogenesis. First, any genetic factor or she had immunological risk factors. Environmental factor lead to abnormal placentation, because those having this all this genetic and immunological and environmental factor risk factor, they will have an abnormal placentation that lead to placental hypoperfusion, that lead to placental oxidative stress, lead to release of anti-angiogenic factor like SFLT1 that will inhibit the VEGF and PLGF, and that lead to endothelial dysfunction, systemic vascular dysfunction. Then genetically inherited factor contribute to inadequate trophoblast invasion. Trophoblast become vulnerable to more attack by the natural killer cell. The invasion is not facilitated by the UNK cell. If it is like because of defective HLA-G expression, NK cell will activated, the less UNK cell is not activated. If it is like HLA-G expression, if that lead to less UNK cell, actually causing the less cytotoxic, and it will facilitate the production of angiogenic factor PLJ, VEGF, IL-8, IP-10, induce suffered invasion trophoblast. But if it is like HLA-G expression, CD56 will more express and cytotoxic increase angiogenic imbalance. Mother A genotype also HSC2 types. Also there will be lacking most of the activating killer cell immunoglobulin receptor. And the seminal finding, previous exposure to paternal semen plays a protective role of preeclampsia. If paternal alloantigen play a private role in the embryonic cell interaction with maternal immunity, if they don't interact for a long time, then fetal antigen can be considered as a foreign antigen. Another cell dysfunction, myoidiate vasomotor tone, regulate nutrient exchange, modulate inflammation, play a primary role in angiogenesis. The factor, this is the factor. If she had already this factor is factor chronic hypertension, diabetes, renal disease, dyslipidemia, venous thrombophilia, obesity, androgen excessivity, periodontal disease. These are the risk factors for endothelial dysfunction. This is the SFLT that will bind. SFLT receptor is prevent the binding of the VEGF and PLGF that will lead to prevent the angiogenesis. Maternal risk factor, genetic factor, immunological, placental hyperperfusion, oxidative stress, testal endothelial dysfunction. All like stage 1 is abnormal placentation, pass in second trimester. Stage 2 is maternal syndrome that will happen in third trimester. If glomerular endothelitis, proteinuria, vasospasm lead to hypertension, hepatic ischemia, necrosis, capillary rupture, capillary leak lead to pulmonary edema, headache, seizure, phase syndrome, platelet activation, thrombocytopenia, and hemolysis. Then ferritation test related to the vascular resistance, rollover test. If you ask the patient to lie in a supine position, left lateral supine position, then ask him to left lateral, then the BP should be increase that after 2 minutes. MAP is more than 90 ml, 18 to 26, angiotensin infusion test that also increase the BP. Angiotensin infusion test that will urinary Doppler velocimetry between 22 would be presence of persistent notch after 22 weeks of gestational age. Then test due to fetoplacental unit, endocrine function, endothelial dysfunction, oxidative state, serum uric acid level, fibronectin, thrombocytopenia, platelet dysfunction level, high level exercise, iron, transferrin, homeostasis, ascorbic. This is the first time prediction. You should do a combined screening test that like maternal history, like all the maternal age, ethnicity, BMI, chronic maternal medical condition, chronic hypertension, diabetes, SLE, personal family history, and maternal. You take into account the maternal pressure, mean uterine pulsatile index, PLGF, and PAPE. If the risk scoring you will do and combines the scoring system, if it is more than 1 is to 100, then screen positive, you can start low dose aspirin 100 to 150 at night till 36 weeks. In case GP monitoring, serial go scan, screen negative, routine management as pregnancy. Then an ICE is telling you should go for free LGF and SFLT ratio, and ISS is denying. There is no, you can specific cut of SFLT can add diagnosis of prediction. If it is like this prediction of preeclampsia, certain prediction and diagnosis, a patient will not develop if it is less, if 20 weeks gestational age, 20 weeks up to 20 to 34 weeks. If it is less than 38, the patient will not develop preeclampsia at least 1 week. If it is 38 to 85, it will develop within 4 weeks. If it is more than 80, highly suggestive. Same thing after 34 weeks. If less than 38, 38 to 110 and 110. If it is less than 38, patient will like within 1 week, 38 to 110, 4 weeks, and more than 110 already she has developed into, there is chances of late onset preeclampsia. Then the risk factor, mostly the risk factors, the risk factor for gestational scoring system, they have making all this thing, age and maternal age parity and all the risk factors they include. They will make a scoring system that will easy to calculate if score is more than 3. Multiple pregnancy, hypertensive disorder, another is maternal hyperthyroidism is 2 score, family history of preeclampsia, this maternal chronic kidney disease, autoimmune disease, all are for 3. Then gastro prediction, predicting hypertensive gastro score more than 3 at risk of preeclampsia. So you start 75 to 150 mg till 2 days prior to delivery or cesarean delivery. Calcium supplementation can add base 1 to 1.5 gram daily, lower calcium gold standard test. Then prevention of preeclampsia or routine BP measurement, reach antenatal page, measure MAF, maintaining normal behavior, airway access 50 minutes for 3 days in weeks. Calcium supplementation 1.5 to 2.5 gram by low high dose. Low dose is less than 1 gram per day from 20 weeks of gestational age is recommended for women with low calcium intake, trial calcium and pregnancy. Calcium and preeclampsia trial. Calcium prevent decrease the release of hormone and calcium the intestinal calcium concentration decrease muscle contractility. Low dose aspirin should be started when earlier than 16 weeks. Low salt diet, fish oil, and not role in prevention. Starting refers to prevent preeclampsia because the estimated oxygen is one expression with stability release. Metformin also inhibit hypoxic indivisible factor 1 by lowering mitochondrial electron transfer chain activity. It reduces SFLT1 SNG soluble endoglinin activity. These are the purpose mechanism. Then the diagnosis of gestational hypertension. Monitoring. How we monitor? Frequency of monitor for gestational hypertension. Blood pressure has to measure serially. Like as per ACOG, weekly BP symptoms, weekly BP monitoring, daily every antenatal visit, once or twice a week, severe hyperadmission to hospital. Nice 2022 once or twice a week. If severe hypertension, I have to admit the patient, and every 15 to 30 minutes you have to monitor till 160 by 110. Target BP has to be 135 by 85. Oxy BP almost mercury. In proteinuria there is serially measurement, NC at serially at NC at least once weekly. Inform report according. She has to report to the hospital if she has developing all these symptoms like headache, visual disturbance, chest pain, dyspnea. This under many virus model. Initial assessment to rule out preeclampsia, to strengthen the diagnostic of rule out preeclampsia. All the tests you have to do: hemoglobin, platelet count, pH profile, headache to strengthen the diagnosis. Angiogenic factor also you can do. The proteinuria weekly you have to do. Then as per NICE 2022, hypertension, proteinuria once or twice week, severe hypertension daily while admitted. If it is mild hypertension, gestational hypertension, has once or twice week, more than 160 by 10 daily while admitted. Blood test weekly, page best test once only if suspicion preeclampsia. Then gestational hypertension, fetal biometry AFI start from 24 weeks as 2022 diagnosis, then 2 weekly, like all are like 3 to 4 weekly. If they develop FGR, then you go for every 2 weekly, AFI weekly. Then umbilical Doppler started from 26 weeks. If it is like FGR diagnose, umbilical artery PI more than umbilical artery PM weekly more than 95 percentile. ADF twice weekly and RADF thrice weekly. And NST, CTG, ADF, RADF have to do daily. Fetal assessment, weekly antibiotic testing, FHR every NC, ultrasound every 2 to 4 weeks, like same thing. Severe hypertension persist. Initial assessment. Then preeclampsia, the blood pressure, serial monitoring, SSP without severe feature, home management, ACOG 19, and admit the patient if high risk. If is 48 year, if high risk, BP every 48 hours at least or more frequent if admitted. Severe hypertension, you should admit the patient. The target BP is 135 by 85. Like you should ask the patient pulpira's model should include the following component: maternal testing, gestational age. If proteinuria, if 1 plus, then you have to do a serial test to if you absent initially, then assess serially. Blood test. If it is less than negative, then you have to assess serially. Otherwise, not. Blood test twice weekly. Serial insufficient evidence for evaluation with angiogenic markers. Once established more than 2, no need to do further quantitative. Once established, there is no need to further quantitative assessment. Then blood pressure, blood test, everything is over. Then preeclampsia, fetal biometry, a diagnosis. Diagnosis, then every 2 weeks, like same thing. ADF twice weekly, thrice weekly, less than 30, and if at less than 34 weeks when there is FGR, you have to do Doppler to rule out the assessment of perinatal outcome. IDF again, they are against the use of biophysical monitoring. ACOG also like the almost same. And ICE 2020, FHR every ANC, ultrasound every 2 weeks if normal. Proxy initial Then frequency monitoring blood pressure, rule out suprapus preeclampsia. Home BP monitoring should be done. Each NC visits has to proteinuria have to test it. As per ISSP, chronic hypertension, you have to do each NC visit to blood test, all the initial assessment there for serially each visit minimum 20 to 30 weeks. Additional testing like serum electrolyte, renal ultrasound if creatine are normal, and LDH PS for histiocyte if hemolysis is suspected, and 24-hour urine protein and serum albumin if nephrotic syndrome is suspected. Then routine use of other tests like to rule out other secondary cause not needed. ACOG recommended to start antihypertensive 145 140 by 90 or radiation medical therapy for chronic hypertension. That's our CHAP study. More frequent testing in second half of pregnancy. If BP is more than 160 110, 50 minutes persist. Initial assessment proteinuria, then subsequent comparison is to needed age. HCG echo as appropriate. Then ICC same like almost same. Home BP monitoring. But Foxy 2021 maternal ECG 2D echo funduscopy. Nowhere they mention about funduscopy, I think so. Frequency of monitoring. Frequency fetal biometry from 26 to weeks, almost same monitoring. There is not that much difference. NST if clinical indication, and PLGF testing is denied by SSP, but ICE 2022 is telling you can go for PLGF testing. Then interpreter monitor during labor BP has to measure hourly every 15 to 30 minutes if it is until 160 by 10. Continue antihypertensive during labor, and don't preload before low dose of peptide. Don't routinely limit 30 second level by assisted bath or operative bath unless there will be uncontrolled hypertension. When to deliver, the gestational age, if there is pre-viability, that is terminus of pregnancy should be pre-viability like before 34 weeks, before 24 weeks. Expectant management should be considered, but only hospital where very infant, only those hospital where infant can be NICU facility easily available, and viability 34 weeks onwards you can offer delivery. If it is gas-free eclampsia, you can offer discuss, and maternal increased parental risk if you deliver early. Expectant care till 37 weeks. Chronic hypertension expectant recommended 34 to 36 weeks. Okay, to 34 weeks. Expectant management can after 34 weeks for delivery. 37 weeks initial delivery recommended. Women who reach 40 weeks should be offered delivery. 39 to 40 weeks. Yeah, 39 to 40, 38 to 39 weeks. 37, 39, 38, 30, 40 weeks. Indication of any gestational age: abnormal neurological feature, repeat episodes of hypertension, permanent edema, progressive thrombocytopenia, progressive serum liver enzyme derangement. BP is not controlled with 3 antihypertension dose, maximum dose, abruption, non-reactive fetal heart. In comparison of ISIS 2018 and 2022, urine ACR has been more than equal to 80 mg. They have added in some state recommendation ACR. Then fetal growth restriction they have added cannot be diagnostic criteria superimposed preeclampsia, but now the chronic hypertension can be diagnosed with superimposed preeclampsia. They have evidence of placenta dissection. Because they thought the chronic hypertension patients already they have so compromised, so they should not uteroplacental dysfunction. They added placental abrasion and jejunum embolus, pulmonary edema, rate in preeclampsia diagnosis. Management algorithm for severe preeclampsia, like you admit the patient, maternal fetal assessment, consider maximum treat dangerous hypertension like 180 to 21 T. BP, consider contradiction to conservative like persistent syndrome, all this health syndrome, renal dysfunction, coagulopathy, pre-fetus abduction, fetal compromise. If persistent, absent contraindication, you can initiate 20 to 48 hour observation, can for lung maturation. Less than 34 hours, you can wait for 24 to 48 hours for lung maturation, frequent evaluation, vital sign, daily evaluation, health syndrome, ongoing management, daily maternal assessment, serial evaluation, daily fetal assessment, evaluation, serial growth, and deliver 30 weeks. If contraindication, deliver contraindication, any contraindication, deliver. Hydrogen lateral epidepin 5 mg IV or IM followed by 10 mg. These are the side effect: tachycardia, lateral asthma, precipitation, bradycardia, hypertension, epidepin, tachycardia. You can start with 10 mg IV followed by 20 mg IV in 20 minutes, then 40 mg and 80 mg. Like this you can use. Management persistent hypertension: if the BP is more than 160 by 110, persist for more than 15 minutes or more, or if too severe elevation obtained within 15 minutes, the clinically indicated treatment. The fastest lateral you start with 20 mg IV over 2 minutes. You repeat BP in 10 minutes. If systolic same, then you repeat BP, then you add 40 mg below the below the continue monitor closely. Repeat BP 10 minutes. If it is again 160 by 10, you can add 80 mg, 20, 40, 80. Then again 10 minutes, add 10 administered hydrogen 10 mg over 10 minutes. 20, 40, 80. Then nitrogen. Then repeat BP 10 minutes. If necessary, repeat emergency specialist medical care. Give additional hypertension medication specific orders recommended facility. Once BP achieved, repeat BP every once BP threshold are achieved, repeat BP every 10 minutes for 1 hour, then every 15 minutes for 1 hour, then every 30 minutes for 1 hour, then every hour for 4 hours. Institute addition of weight monitoring. Notify maximum should not be exceed 300 for 24 hours. Active asthma dependence or any history of hospitalization to severe. You can avoid then heart disease, asthma, congestive heart failure, caution asthmatic. Then hydrogen severe hypertension, you can administer 5 mg or 10 mg IV to 1 minutes, 2 minutes. 5 mg 10 mg, repeat BP 160 10 mg. Again you add 10 mg, then repeat BP. Then again you can start with labetalol 20 mg IV. Then repeat BP persistence like same paternal medicine care. And obtain emergency consultation for specialty internal medicine, anesthesia, critical care. Give additional antidiabetes medication for specific order as per them. The once BP threshold achieved, like every 10 minutes for 1 hour, every 10 minutes for 1 hour, every 15 minutes for 10 minutes for every 10 minutes 1 hour, every 15 minutes for 1 hour, like every 30 minutes for 1 hour, every hourly for 4. The same thing like immediate oral epinephrine algorithm. You can start with epinephrine oral 10 mg, repeat BP 10 minutes. Here the repeat BP is 20 minutes. Sometime initially 10 minutes. In labetalol is 10 minutes. 20 minutes. Then again you are 20 mg. Then you get 20 minutes BP at 20 mg. 20 60. Then 20 mg labetalol. Then again the same thing. This maternal fetal medicine center anesthesiologist critical care consultation. As per them you start antihypertensive. Then after once establish the BP, like 140 by 90, every 10 minutes 1 hour, every 15 minutes 1 hour, every 30 minutes 1 hour, every hourly for 4 hours. Then the maximum doses scheduled for continuous IV infusion. Those have the signs symptom of immune phages, eclampsia, 4 to 6 gram loading dose. Excel 100 ml IV fluid over 15 to 20 minutes, begins 2 gram per hour, 100 ml IV in maintenance infusion. Some recommend 1 gram per hour. Monitor maximum toxicity, dependent reflex, some 4 to 6 adjustment infusion, 4 to 7 millicurrent. Then intermediate intramuscular 2 regimen, one is continuous IV infusion, one is intermediate IV injection. Give 4 gram 20% solution IV, let not exceed 1 gram per minute. Follow from within 10 minutes. Then promptly with 10 gram axial alternate buttock, 1 or 5 gram each, typically upper current effective 3 inch. Then minimize if convulsion persists to 15 minutes, then give up to 2 gram IV as a 20% solution at not rate 1 gram per minute. If the woman is larger, 2 minutes, 4 gram IV slowly. Every 4 hours there have to all the monitoring. Then these are the therapeutic range: 2. Millimole, 4.7, more than 7, 10, 4 to 7 therapeutic range, more than 7 loss of patellar reflex, more than 10 respiratory paralysis, more than 25 cardiac arrest. In management of eclampsia, sought for help, IV access 16 to 18. Patient should be placed in the left side to reduce the risk of aspiration, secretion, vomitus, blood, left side, assess breathing, check airway, intubated rapidly, evaluate the pulse, BP, temperature, if pulse not palpable, CPR initiated, breathing, given oxygen 4 to 6 liter breathing, then give oxygen, given oxygen 4 to 6 liter per minute by mask or nasal cannula. Examine the neck rigidity, force convulsion, clean mouth, throat, continue IV infusion 80 ml per hour, catheterize the patient into the chatting, simultaneously invest the blood group, CPC, platelets, sugar, LFT, start max help, magnesium, loading dose 4 gram IV as 10 ml of 50% solution for 5 minutes to 10 gram 50% solution 5 gram each buttock as DPIM injection. Can add 1 ml of lignocaine in same series, maintenance dose of 5 gram every 4 hourly. Then start antihypertensive talks if the actual BP is more than 100. Juicepan regimen you can start. Loading dose IV 4 gram 1 gram per minute followed by an infusion of 1 gram per hour. Juicepan regimen 4 gram at 1 gram per minute, then 1 gram per hour. Standard IV regimen 1 gram per hour. Juicepan regimen. Then labetalol provide ongoing care. Labetalol 10 to 20 mg, then 20 to 80 mg, every 25 maximum 220 mg. Infusion 1 to 2 milligram per minute. You can go for infusion if repeat in 45 minutes needed. Hydrogen you can add it. Monitor vital signs, maintenance strict fluid intake, output charting, maintenance to anticonvulsant antibiotic drugs, provide maintenance dose Ascalton long base for rates, factals, giving its inflammation, plan delivery from mental progressive labor, analysis for obstetric indication only. Status epileptics within 5 minutes, as 5 minutes or more, either continuous clinical and or electrographical seizure activity, recurrent seizure activity without recovery between the seizure, left tilt, maintenance the airway, call for help, ICU admissions, initial stabilization, left tilt, IV access, initial history, baseline history, maxillary for and maxillary anticonvulsant based ICU with the dogger choice, IV Lorazepam 0.1 ml per kg, usually for mg, like and or diazepam 5 to 10 mg for slow IV. If not no IV access, rectal diazepam buccal midazolam. If seizure not controlled, consider admission of penidine or phase from 15 to 20 mg per kg. Still not controlled, intubate the patient, penavability 20 to 20 mg, internal propulsion, general anesthesia, halothane, NMJ blockade. Then after the mother stabilized, continuous electropetal should be recommended. Commence if the pedal artery doesn't begin to recover within 5 minutes, the seizure is recurrent, case for the delivery. Health syndrome classification, tennis classification, physical syndrome, tennis based on the laboratory criteria. 2 out of 3 criteria is partial and 3 criteria is health syndrome. All the criteria left less than 1 log, ST is more than 70, LD is more than 16, police and peripheral is mere. Then VCC classification, the class 1, class 2, class 3. Class 1 is less than 50,000, platelet count, AST, LT more than 70, LES is more than 600, class 2 platelet count more than 50,000 to 1 lakh, AST, LT more than 70, this raised AST, LT, LDH is more than 600, but in class 3 the difference is AST, LT is more than 40, but LDH is more than 600, platelet count is 1 lakh to 1.5 lakh. Okay, then health syndrome management, refer to the Target Care Center, admit the if there is a certificate, admit labor, delivery area, IV accel should be started, antihypertensive should be continued, BP target should be maintained on 60, at least 105, less than 25 limit viability, more than 35 weeks fetal distress. If all these things, maternal distress, eclampsia, DIC, renal failure, abruption, respiratory distress, suspect liver hematoma, yes, then deliver, complete steroid. If no, then you can wait for expected management, complete the steroid coverage, 24 or 48 hour latency, you can deliver. Indication of management during season delivery and health syndrome. Indications: if there are non-reversible fetal status, abnormal fetal presentation, gestation less than 30 weeks, the VSF less than 5, less than 32 weeks, IGR, oligo VSF less than 5, known capsular hematoma, suspected abruption, management during season delivery, general anesthesia for platelet count. If platelet count less than 75, we go for general anesthesia. Transfuse 6 unit platelet if count is less than 40,000, insert subfacial vein, subfacial drain, secondary skin closure, lip subfacial drain, observe bleeding or upper abdomen before closure. Then postpartum care recommendation for women with antepartum hypertension, BP should be monitored at least once daily, once on a day, 3-7 postpartum. Likely to high after bath. Antihypertensive therapy administered antepartum should be continue after bath. Also consideration should be given to administer antihypertensive therapy for any hypertension therapy for 6 days postpartum. The target diastolic BP should be 85 as alternately. Non-steroidal anti-inflammatory drugs postpartum analgesia may be used in women with preeclampsia. If other analysis are ineffective, there is no AKI or the risk factor. If there is no other risk factor, AKI or risk factor, so don't give any sites. Breastfeeding is recommended. Counseling should be provided with the risk of gestational hypertension for patient preeclampsia 15 future pregnancy. There is a chances of 4 patient of 15% in future pregnancy. 3 month postpartum, all women should be reviewed to ensure that BP urine analysis laboratory. After 3 months, there will be BP and day twice daily. Then 6 month postpartum, the BP should be normal 120 following hypertension pregnancy, particularly implicit counseling about the risk. So, but none of the guidelines promote either cesarean delivery and vaginal delivery. Even in earlier gestational age, an attempt for vaginal delivery can be made through a polio rate is high. Although, if maternal fetal deterioration noted, induction delivery can be continued. Not noted, a decision need to be taken based on the how likely vaginal facility exam case. Thank you.